So thank you very much for that humbling introduction, and I appreciate you all taking time to hear from me in Zimbabwe. As was mentioned, I'm a biomedical engineering professional, and as engineers, essentially it's how we think design, we think change, we think problem solving. And today I'd just like to share some of that thinking with you and how we see it playing a significant role in low resource setting for management of healthcare equipment and for innovation. So just to give you an overview of what my talk will look like, we will just go through some basic principles of healthcare technology, management of healthcare technology, our role as biomedical engineers, how we think we could raise the standard of cleft care. And for this, I will say I'm probably someone who knows the least about cleft care on this teleconference, but the principles of healthcare technology management are the same. We'll also share a bit about digital health and how we could start thinking about developing our own healthcare technology programs wherever we are across Africa. So in a nutshell, healthcare technology, we look at it as applying technology to the healthcare system, any part of the healthcare system. This could be our interaction with patients, it could be for communication, it could be for public health interactions, but essentially how we apply technology to the healthcare sector. There are several benefits of healthcare technology, as most of you would already know. The main one of which in our context would be improving healthcare access, particularly in those remote areas. This plays a very pivotal role in us reaching those underserved populations in our communities. It also helps us with communication, improving our operations, be it for healthcare or healthcare businesses. And healthcare technology also prevents us from wastage. You'll see in a lot of our contexts, some countries are still using a lot of paper-based technology, which generates a lot of waste. And migrating to digital platforms prevents us from wastage. It also helps in the public sector, where I'm currently involved in, with decision making. Right now, you'll see there's a lot of analytics that is taking place using advanced computing systems. It helps us with making decisions for policy, right down to the healthcare facility level. So there are many other advantages, but in essence, we would like for us in this discussion to talk about the innovation around healthcare technology itself. So we're talking about moving an existing idea or object into a product that meets our healthcare needs. So you'll see in Africa, for example, a lot of our innovation that we talk about is essentially making our existing technologies more appropriate for our context. That is the type of innovation that we mostly speak about as biomedical engineers. But of course, it can also encompass making something completely new for our context. Before we get into the technicalities, I thought I'd just take a moment to discuss some of the myths that are around technology that I've personally encountered as a biomedical engineer, both in public and private sectors. There's a big fear around technology causing job losses. Most people will say, I can't embrace technology because I'll lose my job. There are also fears around Africa not being able to afford technologies. And I will go into this myth in detail, and you'll see it's not quite a true myth. There are also fears around security breaches, particularly for digital systems being too high. Fears around steep learning curves, particularly with older generations or older professionals who feel the technology is too difficult to learn. There are also fears around, for example, when we have our star surgeons or star anesthetists, we fear that teaching them new technologies might make them leave our practices because we are putting too much of a burden on them. This one is my personal favorite, where there are people who have actually said to me, this technology is for you young ones. And it's absolutely not true, and we will go through that and see why. This myth that teens feel that they can do without IT or engineering teams in their facilities is also somewhat of a myth, and we'll go through why collaboration is very important to debunk that myth. I'd like to give you a few insights on job statistics, actually. You'll see the likes of McKinsey and World Economic Forum have actually gone into depth to discuss why it's actually not true that technology causes job loss. In fact, it creates more jobs than it displaces. But what we need to start thinking about as healthcare professionals is how can I upskill myself to keep moving together with the new technologies that are being introduced. Of course, technology does displace some older jobs, but it does create more jobs than it displaces. We need to learn to upskill, to learn to use that new tablet we've been putting away, to learn to actually access our emails properly, use the new video laryngoscopes that are coming up, and move with the times in order for us to be able to access those new jobs that will be coming as technology rises. Another myth that is very important I'd like to zone in on is that Africa cannot afford advanced technologies. You'll see an example I'd like to give is that of Zambia, where there is a Zambia government invested in a high-tech modern cancer treatment center. And in that center, I think the investment was roughly around $10 million, if I'm not mistaken. And it was observed that by investing in that one piece of technology, there was a 48-fold increase in the patients that were reached by that technology between 2006 and 2012. And having observed some significant cost savings from that investment, the government further went to invest in more and more equipment. What this shows us is it does take us what might seem like a difficult investment for us to reach more patients, but over the long term, it causes us significant savings when we make the right investments for our context. Frost and Sullivan also supports this argument where there's an interesting new technology called artificial intelligence, very small part of the healthcare technology sector, but itself it is projecting a $6.7 billion revenue just by that one piece of technology. So we see that investing in these new technologies actually provides us access to more revenue in our context. But the question we need to ask ourselves is this new piece of technology worth investing in, and what problem will it solve for our context, rather than thinking of it being something we cannot afford. One other myth I would like to just briefly discuss is that of security breaches. And I think for a lot of us, this is our biggest fear, that our information is too vulnerable, our patients are being exposed by us investing in digital systems. However, it's from research that has been done by the Healthcare Information Privacy Protection Act Journal, estimates that 91% of security breaches are actually coming from those phishing emails. Whenever we get those emails that we click on a link that we don't know, or when we open emails from people we don't know, the human element is what's actually exposing our systems to security breaches rather than the system itself. What this says to us is, instead of us having an attitude towards our technology, we need to weigh the benefit versus the risk and upskill our staff and ourselves to ensure that we are protecting our systems as much as our systems are serving us. I would also like to then move into a bit of some theory. Please bear with me, but it's part of our discussion on how we think around healthcare technology and how it serves us. So with healthcare technology management, essentially we are talking about the planning and management around healthcare technology assets. We are essentially trying to cover a few things. The first of which being making sure our equipment is appropriate. You will find throughout the presentation, I will use the word appropriate a lot, because this is a key concern for us in our African context. Is our technology appropriate for what we are trying to achieve? So essentially with appropriacy, we are saying how our equipment is functioning in our particular environment, and for how much it costs for us to not only procure it, but to manage it. When we talk about risk, the equipment that we are investing in for our cleft care, is it safe for our users, in particular in our context? Is it safe for our beneficiaries? Cost effectiveness. With our resources, especially in our low resource setting, is it cost effective for us to invest in that high-tech equipment that's coming from first world countries, or should we rethink how we invest in our technologies in our context? Sustainability, we are talking about making sure that the healthcare technology we are using has a maximum lifespan, using minimal resources. This is very important. Sometimes we tend to invest in equipment, either through donations or direct purchases, that has a short lifespan, and we try to stretch that lifespan by making unrealistic financial supportive measures. So we need to, right from the beginning, make adequate assessments to make sure that our lifespan will be maximized, but at the same time, we're using as few resources as possible to achieve that. A very important element is compliance. This one is a key concern in Africa, where some regulatory authorities may not be as strong as others, but we need to make sure that whatever we're investing is in complying with public health policies or government policies, as well as regulatory authorities, particularly for medical devices if they are in your country or in the region. In summary, what we're trying to say is, as if we make sure that we are optimally managing our equipment, it will make sure that we have optimal performance. There are three key elements that whose intersection essentially defines healthcare technology management. That is the people element, where we're considering how safe our patients are. There is the financial element, which is a very big driving muscle for healthcare technology because it affects our procurement, it affects how we manage the equipment. Then there's the technology itself. For procurement and maintenance, that's what I would like to focus on as an engineer, which is what I know most. But essentially, when we're talking about procurement and maintenance, there's the assessment. So these assessments are quite pivotal to making sure our equipment is sustainable to meet both our long and short-term needs. There's also a project management aspect. For example, when you procure your equipment for your theaters or for your centers, these are short to medium-term projects that have defined windows, such as the installations and the accompanying trainings, which are also part of that facet of procurement and maintenance. The aim there is essentially to make sure that we are efficiently running our equipment. Then there's the asset management aspect. I would like to emphasize that from my experience with various facilities I've interacted with, this seems to be a lacking element simply because there's a lack of ownership across the board and poor documentation for how our equipment or assets are being managed. The general standard is when we have equipment, they should be, just like we have with finance, we audit our equipment, we have registers. That function should be owned by everyone in the equipment management cycle to make sure there's clear documentation, and that we should not be too stringent with our resources for service and maintenance. Because when we procure equipment, it seems we tend to take shortcuts with then releasing finances for managing equipment. But that has serious implications on the lifespan of the equipment and needs to be paid enough attention, essentially to make sure our equipment is sustainable and serves its maximum lifespan. So when we look deeper into the aspect of the finances and procurement and maintenance of our technology, there is a very crucial step that is of asset management, which is an entry point to our equipment life cycle, as I alluded to earlier. So the assessment essentially takes place whenever the likes of a clinician or a group of collaborators come and identify a need and say, we have a problem, let's assess our needs and our context and see what we require for us to be able to operate more effectively. So our healthcare technology life cycle looks as such, where we first carry out our assessments, and then our financial collaborators support us with budgeting in order to make sure we procure the right equipment for what we can actually afford. it's very important for these steps to be done thoroughly and not to rush this process, because it has an effect on how we manage our equipment. Then there's, of course, the obvious steps, the acquisition of the equipment and supportive activities that we all are aware of, education around how to make use of it, the compliance, maintenance, the safety, and it goes on until we realize that our equipment has now reached its end of its life cycle. At that point, we reach a point which a lot of entities tend to neglect, which is the disposal. Now, I will say the disposal of equipment should be considered right at the beginning, and we'll see why. But you see, some entities are not even aware of the disposal regulations that are in country, and these should be considered right before we purchase or receive donations. If they are non-existing in our countries, we need to be able to push for the right policies to be in place so that we don't have equipment wastage or dumping, or perhaps to affect our environment. So also to do with our needs assessments for healthcare technology, it's very important for us to understand what our barriers to technology are when we're doing these assessments. Not understanding what these barriers are can actually make us solve the wrong problem. As our entry point to needs assessment is to first identify the problem, we need to make sure that our problem is very clear, not only to ourselves as doctors or surgeons or anesthetists and maybe the IT personnel, but it also needs to be clear to the novice. So if you find that as a team, we are defining or explaining a problem, or failing to explain a problem rather, to our non-technical counterparts or even to your family, then there is a problem with the problem definition itself. So we need to make it a habit to have, of course, a technical definition, but to also ping that definition to non-technical experts in order to be sure that we are solving the right problem that can be understood by the public. In Africa, of course, our needs vary from region to region, country to country, depending on socioeconomic factors. For example, for us in Zimbabwe, our needs are very different from the needs of South Africa. We are both in the same continent, but South Africa may have more medical device development activity than we do in Zimbabwe. So we need to make it clear that we are solving problems for our context, for our disease burden, and to make sure that we are not causing a disruption to the whole healthcare system when we're defining our needs. But generally, we'll say in Africa, of course, infectious diseases and poverty burden tend to be the driving factors for public health investment, which is why you'll find it may be easier to access funding for equipment in that sector than it is to access funding for maybe our cleft lip and palate surgical equipment. Not to say that it is less important, but it may help understand why there may be a bit of a frustration in trying to access funding for our initiatives. So as I said, understanding the barriers, that involves engaging our community. So the community is very key and should be involved whenever we are trying to come up with new piece of technology to introduce, because the community actually carries a very big muscle when it comes to pushing forward our new interventions or innovations. So typically you'll find the likes of skills gaps, community resistance, inadequacy of equipment are all barriers to healthcare technology access, but I cannot emphasize enough the role of community in our assessment, and they need to be engaged throughout the process. So essentially, this is what our needs assessment looks like, and all the inputs to our technology needs assessment. It needs to be affordable, of course, safe, effective, accurate in terms of doing what it intended to do, accessible, appropriate, as I mentioned earlier, sustainable. But what I would like to discuss a bit further is it needs to be multidisciplinary. what we have seen is that whenever there is a mismatch between our technology that we're working with and the problem we're trying to solve, it usually is reflective of there being poor collaboration across different teams or sectors, or a general poor understanding of the problem or the context. So what we mean by collaboration or multidisciplinary is we need to include the right people for solving the problem. Generally, a team would consist of your financial experts, of course, who will help us with the right budgeting, your biomedical engineering technicians, which are sometimes missing from this problem or needs assessment. It includes our clinicians, our patients. Sometimes we need to be interviewed to see what their patient experience preferences are, IT professionals, policymakers, regulatory authorities, as I alluded to earlier, community leaders, and opinion leaders where possible. For example, here in Zimbabwe, it's very possible for you to come with a very bright idea for how you're going to penetrate the community. But the minute you reach to higher levels in the rural communities, by the time you get to the chief, they can really tell you to go back to the bottom line and start your correct protocol for how a chief is supposed to be addressed. So it's very important for us to have a clear representation of all the major stakeholders, and these are people who have potential to change direction for where you're trying to go with your intervention. So in terms of collaboration, our stakeholders need to be engaged throughout, right from the beginning to from your initial problem identification, all the way to all the stages of iterative problem refinement, which are typical in nature for our needs assessment. What we've seen is a lot of teams tend to collaborate very well with technologists, clinicians at the initial stages, but as the problem evolves or is refined, the scope tends to creep and change direction, and we tend to cut out other key collaborators. So it's very essential to keep pulling all your collaborators in order to make sure your design is holistic. Just going to pause and see there are a few raised hands and see if there's anything I need to immediately address. Okay, so maybe I'll just address a few things at the end of the presentation. If you don't mind, I'll just continue. So just to bring it home, there's a very interesting publication that came across, which discusses the big subject of donations in low resource settings. Of course, a lot of our equipment is donated, but what most of you would know is there's not a lot of healthcare technology development happening in our context. So we tend to rely on donations. But what tends to happen is we are often nicknamed equipment graveyards as a result, because this is where equipment tends to come and die, unfortunately. Other countries such as South Africa have actually seen that they've been relying a lot on imports, particularly imported parts. And this has really been exposed in a lot of countries by the COVID-19 pandemic, where parts that have been coming from countries like China are no longer coming into our countries either for development or for pieces of equipment, which has brought to light that we really need to be more innovative in our own context, using our own resource to keep our healthcare service delivery going. There are a few challenges cited in this publication that I thought are worth sharing. Sorry, I skipped the gun here. So some of the challenges that are cited is that the dumping of obsolete equipment from high-income countries is posing a challenge for us. However, on our end, we find it culturally inappropriate to say no to these donations simply because they are free and countries are showing their kindness. But we have infrastructure gaps that don't support some of the equipment that we've been receiving. You'll find some of the designs are inappropriate. In our context, for example, we have a lot of hot and dry weather, or a lot of power outages, which do not support some of the high voltage equipment we've been receiving, and makes it difficult to operationalize this equipment. You also find, unfortunately though, that of the equipment that's coming to low to middle income countries, 40% of it is out of service compared to our high income country counterparts, where only 1% of it is on average out of service. Essentially, the largest problem in our context is there's generally lack of management of the healthcare technology, which is causing a lot of these the downtime. According to the WHO, the estimates are that 95% of medical equipment in our low to middle income countries is imported, with 80% being funded by international donors. What I perceive to be a sad statistic is that while 70% of the medical equipment in sub-Saharan Africa is donated, only 10 to 30% of it becomes operational. We've personally encountered equipment that has been donated, for example, but is never completely commissioned, simply because maybe someone just didn't do the complete training to the staff that are on site to make sure there's on-site adoption. You also find some of the challenges are that the companies that come and do the installation do not share the resources or the manuals that are required by the local staff in order to maintain this equipment or to keep it operational. So from our context, our general challenges are that our equipment then tends to have short life cycles. It tends to then be dumped, and we have incapacitated first-line support staff. These are largely our technicians who are meant to keep our equipment running. There is limited first-line support, and also a general lack of a problem-solving mindset. Here, an example I could give is I've personally had an experience of clinicians who would call engineers to come and troubleshoot a big piece of equipment while a patient is waiting, only for the technician to come there and see the machine was never powered on. These are very real examples where we really need to encourage ourselves as clinicians to develop a problem-solving mindset and to actually learn some of the language that is used with the communication of fault to our counterparts, who then help us with troubleshooting. The perception that handling equipment is probably not my job, it's for someone who has the screwdriver or knows how to manage a computer. It's true in a sense, but essentially we are all custodians of this equipment and need to be part of the management process. Generally, you see, on the other hand, on a larger scale, there's not enough policy to support management of equipment or budgets to make sure that equipment is readily available. So we need to be advocates, sitting in those meetings where we speak for more funds to be released and more infrastructure to be directed towards our cause. And then when it comes to actual donations, we need to make sure our contracts are secured for maintenance right at the time of procurement. And these conditions tend to be lacking in our policy documents, where, at least in some countries, it's not made mandatory for you to have a maintenance contract in your donation negotiation process. But perhaps we need to start thinking around how we need to make sure that when we are receiving our donations, we negotiate right from the beginning that there should be some kind of maintenance arrangement for at least 1 to 2 years of our equipment operation. Here is just a visual from an equipment dump site in Malawi, and it just really shows you the gravity of our problem, that we really need to be careful about the equipment we are procuring and have clear disposal protocols. I'd like to move to the left a little bit and talk about the models we can think of using in our context for supporting healthcare technology management. Some institutions that are more established will have an in-house biomedical engineering unit that will have some engineers, some IT personnel, and maybe some clinicians who are collaborating with that team to break down the medical jargon. But for this, I will highlight that some institutions need to be very careful before having this approach, because you need to be sure that your skills to equipment ratio is supporting this model. What we mean by that is if you have one piece of equipment and then you have a full-time team of 3 engineers that you need to pay every month for a full year, it may not make financial sense. There are alternative models to consider. And you'd also need to consider how frequently your equipment fails. So if you have equipment that is less likely to fail, you may not need someone there full time. But it is one model you can use if you have a lot of equipment in one place and you need a dedicated team. Alternatively, you could consider outsourcing, whether locally or foreign, but this also attracts its own costs in making sure that your engineers are there on time to respond to equipment that is down. For this, I will highlight that it is our responsibility as clinicians to make sure that we learn how to clearly communicate faults of equipment. It may not be enough to say my computer is down or is quiet. You may need to explain what happened before it went down, what procedures you tried to at least make sure it's working, and make sure we just learn the right language to communicate to our support staff. Other entities tend to use shared services model. This can be within one entity or a larger or multiple organizations that share service. So we could consider having one practice and another practice sharing a similar team. And this is what I would recommend where finances are stretched, where you share a same IT group or company, that you make sure you agree on how the structure of payment is going to work out, and ensure that you have a clear task sharing agreement. Finally, a very important aspect is the actual capacity development, which needs to support all the other aspects of healthcare technology management, which would include trainings and having support from academic programs. You'll see what happens with some of our staff. They might know how to install equipment because usually the manufacturer also comes to help with installation with their own engineers. But when the manufacturing company leaves, our technical staff don't know how to adequately support ongoing problems. So what we need to think about is investing where possible in sending our technical staff, by that I mean the maybe engineers or IT professionals, to go to the actual manufacturer and be trained bottom up how to manage the equipment. It might be expensive at the beginning, but over the long term, it drops the cost. Entrepreneurship is a very broad term, and we use it very loosely to describe someone who's starting their own thing, which is fair. In Africa, actually, interestingly, we have, as a continent, the highest rates of adults who are starting new businesses. And we also have a lot of women in the world who are starting businesses. Very interesting, which shows us that we have appetite for entrepreneurship, we have appetite for innovation. Unfortunately, though, the proportion of those new ventures that is actually manufacturing entities is very small. The reason we have that is because in our context, we are largely focusing on entrepreneurship that is more driven by necessity, means to an end. It's usually driven by lack of opportunities. We're trying to create employment. And we usually try to avoid barriers, but you find in more developed contexts, they tend to focus on opportunity and use that as a vehicle for delivering innovation. What we need to start migrating towards in our context is to look at our opportunities, develop the necessary skill to make sure that we are innovatively creating new technology that works for us and penetrate those barriers rather than avoiding them. So we need to create an environment that encourages entrepreneurship in order for us to innovate. I would like to just show you a very short clip. I'll probably move a bit quicker through my remaining slides, but I thought it would be interesting to share this little clip that discusses a case in Uganda of what innovation looked like. Okay, so this little clip I thought would be interesting to share for us to start thinking about how we can use what we already know in our context to create more frugal designs for our context. You see in this case, they recognize that the midwife would be using that horn to listen to fetal heart rates, but unfortunately it required a certain level of skill which would minimize the number of people that can deliver this service, as well as just generally introducing high error rates if used by someone who's not skilled. What we need to start talking about is how we can frugally design solutions for our context. And when we talk about frugal biodesign, essentially, we need to understand our context because it helps us drive down our costs, introduces practical innovation, and prevents wastage. There are several elements that go into that. Of course, the interaction with the experts in the field, such as yourselves, the development of the product itself, which is multidisciplinary. But other elements that are very key are intellectual property. You'll find in our context, we tend to ignore the subject of intellectual property or IP because we believe our solution is not novel enough, which may not be true. We need to think around how we protect our intellectual property in our context. And if we're not aware of what these bodies are or in our context, we need to make sure it's our business to find out who can help us with protecting with our IP and making sure that our technology can be scalable to other low to middle income countries. We also need to make sure that in the design process, we include an element of communicating our innovation to the public so that it's readily adopted, and also think about how we're going to finance it and adhere to regulations. I'd like to briefly just touch on some of the potential that's coming from our context. There's some very innovative smart jackets that are coming up from Uganda, a company called Mama Up, I think. I hope I pronounced that correctly, but it's basically identifying the problem of high death rate, high mortality, child mortality from pneumonia, and trying to improve diagnoses using a smart jacket that has telemedicine capability. Closer to Central Africa, we have an upcoming company called Ultra Red that is doing a lot of 3D printing, also serving the healthcare sector, where in the COVID-19 pandemic, they're printing PPE. They're also printing some complex geometry, such as the pelvis, as you see there. I don't know if some of us are aware of this, but there's also a portable surgical unit that has come from Nigeria through a collaborative exercise with European colleagues, where it was actually inspired by an anesthetist who got tired of going into theater, not having enough resources to carry out procedures, and also not being able to access remote areas. So a compact OR that's also termed hospital in a box was created, which has an ECG, surgical lighting, and anesthetic machine, essentially which can even be put on a helicopter and taken to remote areas for carrying out surgery. Essentially, what I'm trying to show you is we have a lot of potential in our context, but we just need to make it more appropriate for our setting. I think time is moving faster than I thought, but I hope these slides will be shared. But there are some ethical considerations that need to go into our design, and we need to be aware of the bodies that support our ethics and regulation for medical devices. The likes of the Global Harmonization Task Force, wing of the WHO, ISO standards, and the FDA. And of course, in our region, we have multiple entities in our respective countries. But what I will say, though, is a lot of donors, if we're looking for donated equipment, tend to require ISO certification, or yes, ISO certification 9001, which is quality management, and 13485, which is for medical devices. So it would be worthwhile just getting a rough idea of what these standards involve and how they can help you get more access to equipment. So in terms of our cleft care, I'd like to strongly encourage all of us to think outside of a box in terms of how we are delivering care, but how we are also training ourselves to be ready for our surgery. It's unfortunate that we tend to focus on some of these diseases such as HIV, but you'll find it's actually, I'm sure a lot of you already know, much cheaper for us to deliver cleft care to our patients than it is to manage HIV. So now we just need to ensure that we are heard in terms of delivering our care and be more innovative around how we are going to do that. For our innovation in terms of training, we came across some work that's being done in Toronto, which is using 3D printing, where I understand some styrofoam cups have been used for training for cleft care, for cleft surgery. Alternatively, we could look into 3D printing and see how that drives down our costs for training. Here there is an example of a little model that's been created of a child's mouth in order for a surgeon to practice repeatedly how they're going to carry out the surgery. We need to think about whether or not this is a worthwhile investment for Africa, and if we could help us with our training. We should also start thinking about who should be the right stewards for our technology. I cannot give that answer. I can only hazard a guess, but there are multiple people that need to be potentially identified for being stewards of our technology. By that we mean these are people who have a balanced understanding of the community as well as technology in order to be able to lead us all in addressing the problems that we have in managing our technology and delivering our service. So these question marks I've left, that's entirely up to us to all decide for our teams, but these are people that need to be tasked carrying our agenda forward. I'll quickly move this, but we could also start thinking about, when we're talking about collaboration, do we even know what our network looks like? Do we know who the key players are in our cleft care system? So if we don't, we can look to technology and analytics for this answer to be able to know, okay, there's an NGO in Nigeria, one in South Africa that's having a similar agenda as us. How can we visualize this network in order to attract more funding, to leverage more knowledge, and to use the resources that are available rather than looking to high-income country counterparts? We'll quickly move through digital health. It's also important for us to not ignore the role that digital health plays in our context, because it's actually it's got a very strong potential in Africa. And a lot of our systems rely on mobile health, mobile applications, and you'll find that actually in Africa we have the fastest growing mobile subscription rate in the world. So it's up to us to think of how we can improve healthcare access with digital health in the form of mobile health to help us with clinical decision making, point of care diagnostics, and managing our surgical interventions. I'd like to just inspire you that although we are in a very troublesome and difficult pandemic, you'll find there are actually countries that are taking advantage of this time to innovate. The likes of Ghana that are using drones for delivery of services, and also you'll find teleconferencing like we're doing now is actually on the rise, and there are companies like Zoom that are growing to 300 million subscription rates per day. So it's up to us to now think, how can we use this digital era to our advantage in cleft care? What we've seen that could potentially be a solution is there is an augmented reality solution that's been made available by a company called Proximi that facilitates remote surgery. If one experienced clinician is perhaps in the United States or Europe or India or wherever, they could guide someone that is here in Zimbabwe or Nigeria on how to carry out their performance, right from the landmarking to the actual intervention. This could also be a potential solution for our training, for remote training. Right now is the best time for us to consider investing in augmented reality, which essentially means interacting with something from afar, but actually having an impact on where you're making your changes digitally from here. So we need to think about, maybe it's an opportunity for training and mentorship guidance for cleft lip and palate surgery. As I approach the conclusion, I'd just like to say there are a few initiatives that are already existing for setting up programs. One of which is the African Biomedical Engineering Mobility Project, which which invites institutions or individuals for participation. There are scholarships for that, and also you could approach any of these institutions or partners of that program for guidance on how to set up your own project to do with healthcare technology management in your setting. I'd also just like to highlight a few interesting resources or readings which you could look into, which have informed this presentation. And perhaps just to summarize, healthcare technology is key for improving our health outcomes, and we need to make sure we address some of our myths by upskilling ourselves. Technology management is key to achieving optimal technology performance, and one of the key steps in that is making accurate technology assessments involving the right stakeholders and partners. Our community is key to adoption of this technology, and we need to make sure our problem is adequately solved by understanding our context. We need to also make sure that donated technology is thoroughly assessed, including having appropriate maintenance contracts, as well as having clear support models for our equipment. We need to facilitate a culture of entrepreneurship in Africa and make sure that we think outside the box. Finally, I just want to say, let us leverage digital health as a vehicle to innovation. Thank you very much. I think I'll stop here and maybe give some time for some quick reactions or questions or discussion.
Thank you so much, Ms. CHIPO, for this illuminating lecture. It's so comprehensive and very enlightening. I want to thank you for this. We want participants to send their questions to Q&A. There's a question in Q&A, but it's in French, but luckily it has been translated. I'll read it to you. So that you hearing me? Yeah, yes, right. It says the way medical equipment ends up in Africa can bring tears to your eyes. Isn't it possible to attach biomedical technicians to surgical missions? In this way, clinical and surgical knowledge will be passed on at the same time as knowledge about the upkeep and maintenance of the equipment.
Okay, I want to be sure I understood you. You're asking whether it's possible to attach biomedical technicians to health facilities.
Yeah, right.
Yes, it's very possible. In fact, there are some entities that I already know that do that in Zimbabwe, where you have students from universities being attached to clinical facilities in order to have more contextual understanding of how the clinical practices work, what the problems are. But there's also the biggest bottleneck to that is funding and maybe lack of collaboration at higher levels, where perhaps the students are interested, the departments are interested, but right at the top, there may be a lack of or a siloed implementation of healthcare service delivery between the healthcare sector and maybe the education sector, or within the sector they are siloed. So what we need to for as clinicians is a platform that is multidisciplinary and also includes academia to make sure that all the stakeholders have their interests balanced before setting up these programs, and to make sure that there's a clear path for how the students are going to be absorbed into the healthcare system after they do their attachments or short-term trainings. I hope that answers the question.
Thank you very much. Looking at the presentation, you say that most of these ideas you have brought in needs the buy-in of policymakers. Mm-hmm. Because as clinicians, we are at very low rung of the table. How do you think, because if there is no national policy that guides this, it might be almost impossible, especially with a donor-dependent lifestyle in Africa. What do you think can be done? How can we now start articulating this and advocating for it as practitioners so that we can drive, we can now provide the initiative and drive it?
Okay, so I'll answer that in two ways. There's a very quick start, practical way of doing it, and a more technical way of looking at it. So the quick start way of doing it is within your network, you could set up I don't know if you want to call it a consortium or a task force that is responsible for driving that agenda. For example, you could have a few surgeons, anesthetists, or some healthcare associations that come together and draft an agenda to say these are the outcomes and that we want to achieve. And in also then having a structured agenda, then approach the relevant ministerial departments and present that interest. You'll find there's some file probably sitting in a government office somewhere that has a similar agenda, but maybe hasn't had the right stewards to carry it forward, as I was mentioning. So these bodies, as long as you have a clearly defined set of objectives, what you're trying to achieve, and the people that you'd like to approach, and when we then approach our ministries, they should be a key to unlocking other sources of collaboration or donor participation if we are consistent. A technical way of looking at it, as I mentioned, I know I rushed through it because of time, was to have a clear understanding of what your network looks like. So right now, I mean, I obviously don't know all the cleft lip and palate NGOs that are there. Of course, there's the likes of Smile Train, Global Smile Foundation. But if we understand who's working in Africa, what their footprint looks like, and make sure we draw the necessary links. For example, if we say there's this government entity or NGO that's working on technology, one is working on the actual surgical trainings, and make sure we have a clear map of who's doing what, it becomes easier to then motivate for policy change. It also becomes easier to motivate to attract more funding, because we have a clear picture of where we are working, where our money is going, who's working with who. And you'll be surprised to find maybe there's entities working individually on the same thing all over Africa, instead of creating one big vehicle to serve the big agenda. So in short, I'll say we need to have a clear picture of our network, and then we need to have a task force that we elect that is multidisciplinary, that can then approach government stakeholders for participation.
Thank you very much for this wonderful presentation. I think I need to commend Smile Train for bringing you on board, and commend what Smile Train is doing in Africa. They are not just coming in to just give us fish. They are training us how to fish, and this is part of the capacity building they are giving to us. And I'm happy to say that Smile Train is even looking at bringing in biomedical engineers to help us with our resources and train our own biomedical engineers at least in Nigeria. I know that is coming up very soon. And I think it's something that we really need to look at. For us to have a sustainable program, these are things we really need to do. Apart from our skills, we need to have the wherewithal to be able to provide the treatment and services we need to provide. But we also need to win ourselves from this donor dependence, so that we can now be more strategic and be able to plan and know what we're having and plan appropriately for sustainability. But on behalf of everybody, I think it has been a very wonderful presentation. Most people have benefited from this, and there's a lot of congratulatory messages on the chat room that shows that they really enjoy what you have said. Most people are clinicians, and at least you are talking to people who are in policy positions so that they can know how to articulate. But I think this presentation has given them the capacity to really see and to think out of the box, as you have said. So on behalf of Smile Train and West African College of Surgeons, I want to thank you for this wonderful presentation. I hope that we will have you again for more collaboration. Thank you very much. And I hand over to Smile Train. Conclusion. Thank you, Nick.
Thank you very much, Ms. CHIMHUNDU, for that really great presentation. As you all have heard, we have the potential to think for ourselves what works best for ourselves, and those ideas about technology, innovation, and data, they can be derived from us here in Africa. I would say this is the end of our presentation for today. And then those of you who have any additional questions, you are free to email some of us so that we can direct them to Ms. CHIMHUNDU. And I would say have a great day, and see you in our next session next week.
Thank you. Goodbye.
Bye.